that has been noted, and a lot of sensitization amongst the healthcare workers. And basically, this is because of the social media information people are getting and a lot of stuff that even we, the healthcare workers, are buying into. Otherwise, these are quite a number of issues that have bedeviling us. But I have to say, we are trying our level best in offering the services, not at the level of the bigger facilities like the ones which have already presented. Dr. Lois Acheng has presented about what's happening in KTTRH, but we are trying at a small level despite the challenges that we are having. And I believe that we will pull through this other phase if the protocols that have been laid down are going to be followed. Thank you so much.
Thank you very much, Dr. Mbati. We applaud you for the work that you're doing. And indeed, we are very glad that Nyamira has onboarded into the webinars. I think we'll be learning more and more as we go forward. So thank you for that presentation. I guess the one comment I'd want to make is often we are happy that we have a 5-bed or 10-bed ICU, but it's the recognition by the counties that an ICU is more than just the room and the ventilators. It's the personnel, it's the availability of all the supplies that are required. So even if you have that ICU, for you to be able to actually offer critical care, there's a lot more that needs to be put in place. And I recognize you also talked about low staffing leading to very long working hours. Often in critical care, when that happens, then you end up with excess mortality because you're unable to offer the best care. So thank you very much, Dr. Mbati. Allow me now to invite Dr. George Moya, my classmate in medical school. He's a physician in Kericho, and he'll present for us the state of issues in Kericho. George, karibu sana.
Good morning, team.
Good morning.
Can you hear me?
Yes.
So I don't know whether you can be on video. Presenting from Kericho, and I'm joined by my colleague, Dr. Mwikali. She can wave. Yeah? I don't know whether you can see her. She's one of our very hardworking medical officers in our isolation unit. So we'll have the presentation in 2 parts. She'll take us through the first part, like 8 slides, then I finish another 7 slides. So I want to welcome Dr. Mwikali to start our bit.
Good morning. So I'm Dr. Mwikali.
George, are you able to share your the slides?
We're having challenges with the network. Recording in progress.
Are you able to share the slides, please?
I think we are okay now.
Okay.
We've shared.
Yes, yes. Please put on slideshow.
Okay. So I'm Dr. Mwikali from Kisumu County. I'll take us through the COVID-19 status update this month. To start off, we have one of the 14 counties comprising the Lake Region Economic Block. Our population is 901,000. That is per the 2019 census, and we have 6 sub-counties. Our temperature range is 10 to 29 Celsius, and we experience 2 rainy seasons per year. From April to June, then October to December, this coincides with the infection peaks. That is the map of the Lake Region Economic Block. So some of our pictorials, the first top left is our COVID tent. Then the next is our sample collection point. Below that, we have a nursing station. Those are some of the pictures of first picture is of our ICU. Then below that, we have isolation ward. So for the management, we have 136 healthcare facilities. Of this, we have 1 county referral hospital and 3 sub-county hospitals. We have 8 centers, both public and private. We extend our services to patients from neighboring counties. That is Nakuru, Bomet, Nyamira, Narok, and 30% of our COVID patients are from these other counties. 45% are from private facilities. Then we usually have every 2 weeks we have meetings for COVID management progress. So cumulative statistics far, we've done 14,115 tests. Of these, 3,039 are positive. Males were more at 19 or 7. Females at 1,152.
Sorry, Doc. Daktari, just 1 second, please. We can't hear you so well. Dr. Muya, kindly mute one device so we can hear better.
Am I audible now?
Yes, now we can hear you well.
So I was presenting the cumulative statistics as of 16th June. We have done 14,115 tests. Of these, 3,039 were positive. Males were more at 1,907. Females at 1,132. Our positivity rate is 23%. Our total deaths are 135. 132 are facility deaths, then 3 community deaths. 46 were with comorbidities, mostly diabetes, hypertension, and cancers. Our recovery rate, recoveries are 2,910. Currently, we have 77 active cases. This is both public and private sectors. 13 are home-based and 64 in facilities. Then we have 440 healthcare workers who have tested positive. This is the breakdown of the months since March 2020 till now. So our peak, as you can see, has been in April 2021, where we have had a positivity rate of 32%. Yes, and also, as you can note, that was the time that we started using rapid tests. Yes. Yeah. So factors that have contributed to a high caseload in this year. One is increased testing capacity. We're now using both the rapid antigen test and PCR. We're also using Gene Expert in some centers. Then the RDT kits are available in private facilities. Another factor is transfer-ins from other counties. So we had spillovers from Nakuru and neighboring counties. We have a high positivity rate in prisons. Then we have thorough contact tracing in T estates, therefore leading to a high number of positives and less deaths. Vaccination status this far. The first dose, we started giving it on 9th March. So far, we have given 12,516 doses. More males are vaccinated. Males who have received the first dose are 7,605. Females at 4,909. Intersex 2. The second dose is still ongoing. We have administered 3,236. That is as of yesterday, close of business. Males were again more at 1926, females at 1,309. That's the breakdown of the vaccination. First dose, healthcare workers got 2,247. Currently, the second dose, we have given 1,060. Security officers, first dose 899, second dose 290. Teachers, first dose 1855, second dose 322. Then here, the rest as shown. So do we have other variants? We have sent 100 samples to Cambridge, Kilifi for sequencing, but we are still awaiting results. So we don't know if we have other variants. Some of the challenges that we have faced, we have frequent breakdowns of the oxygen plant and delays in repair of the same. Also having challenges with purchasing sufficient oxygen, that is cylinders, the transfer-ins from other counties. We've been having challenges with essential drugs from time to time, then also inadequate vaccines and inadequate staffing. Then the last thing we'll present is a case of vaccine-induced thrombosis and thrombocytopenia. Dr. Muya will take you through that.
So thank you, Dr. Mikali, for the clear presentation. So thank you, Dr. Mikali, for the presentation. Share this of one of our background of vaccination.
Sorry, George, we can't hear you so well.
Is it better now?
Yes, yes.
So we thought we could share an experience of a patient who got thrombosis post-vaccination, the first dose. A 34-year-old teacher who has had history of DVT back in 2010 and who presented 5 days post-vaccination with what looked like acute abdomen stroke upper GIT bleeding. I was called to review the patient after being in the ward for at least a day, and I realized she had features of what looked like acute abdomen with IO and upper GI bleeding. So after seeing her, I ordered for tests to be done. And one of the tests which we did was a CT abdomen pelvis with contrast. And the CT revealed extensive thrombosis involving the mesenteric, portal, and splenic veins. And she had a thrombocytopenia of around 94. After I saw her, we quickly, after getting the history and the way she had presented, and seeing the extent of the thrombosis and the early gut ischemia, I quickly got in touch with the facility in Eldoret for prompt referral because the surgeons this side were at loss on what to do. Some were suggesting that we could open and do the section of the area which was looking ischemic. So we referred that to Eldoret, and my colleague, Dr. Foba in Eldoret, they decided to manage her conservatively. She ended up being in ICU and managed and successfully. They managed, investigated, and I think we can conclusively say the thrombosis was attributable to the vaccination. Currently, she's stable. I saw her last Friday. She's doing well. She's currently on the notes and she's done well. The symptoms have resolved, and we decided we'll put her on as at now, because we don't know how it will behave. We decided she'll be on very long-term anticoagulation. I think I'll stop there.
Thank you very much, George. That's a very interesting presentation. And thank you for even the presentation on where Kericho is in terms of preparedness. So maybe one of the things I'll ask you is, from your perspective, what is the reason that this patient has been put on lifelong anticoagulation? We've read of these stories coming from outside. It's very interesting that we begin to collate and have a database of some of these side effects. But what are some of the reasons that you rightly made the decision to have this patient on lifelong anticoagulation?
Okay, I'll say I came already.
Sorry, we can't hear you so well.
Sorry. You can hear me?
Yes, now we can.
So, so when she came down, already she was on anticoagulation. Ideally, well, I don't know whether we know much about the possibility of a recurrence of the thrombosis. Well, we don't know whether you can say we want to anticoagulate for 3 months, 4 months, 6 months, or 1 year. Since there are many things we don't know about the thrombosis post-vaccination. So one of the things we've decided she'll be on anticoagulation as long as we have any new evidence about it. And number 2, she's not going to get the second dose of vaccination. If there's any new information that will be shared from research, I think we should also be part of that research anyway. It will inform us whether we need to stop the anticoagulation or the span of time she needs to be on anticoagulation. And another interesting bit, I don't know whether the other teams have been sharing, is COVID post-vaccination. We've seen, personally, I've seen over 15 patients who have come down with COVID after the first dose of vaccination, let's say 2 weeks after vaccination. I don't know whether we have any experiences from the other teams.
Yes, thank you very much, George. I think maybe just the one reminder is that first dose of vaccine is not fully protective. And for some of the variants, preliminary data just published as preprint suggests that vaccine protection just after the first dose, for example, against the Delta variant, may only be no more than about 30%. So even after the first dose, people still have to take adequate precautions. So thank you very much for that presentation. We have our last presentation from Dr. Neto. Dr. Neto, you're still with us. Dr. Neto is a clinical pharmacist at JOOTRH. After his presentation, we'll take a few questions. Thank you very much.
Yes, thank you very much, Dr. Luis. I hope you can see my presentation.
Yes, we can, Dr. Neto.
Yeah, thank you very much. Now I'll start with the statistics in Kisumu. Relatively, we have about 6,800 cases. And as of 16th, we were actually reporting 142 cases, in 24 hours. Currently, the active cases we have are 856. Within our facilities, 151 and 705 at home on home-based care. So this is just the statistics within Kisumu County. Now, this is the weekly positivity rate as up to last week. That's the 23rd week of this week, and we can see the up and downs of these waves. So currently, we are still moving up, though we are still not sure if we have leveled out, but we are still monitoring the positivity rate. Now, within Jaramogi Oginga Teaching and Referral Hospital, I'll take us through the admissions and the cases that we have. So cumulatively, we have admitted about 502 cases. The severe ones were about 271 cases. Mortalities that we have had so far, 169 within the JOOTRH isolation unit. There are some patterns which we will want to go through. That is the cases that we have, the age and the gender distribution. Then also a pattern that we have seen again changing from, cases coming from the urban area, and of course getting more cases in the rural areas. Then of course the mortalities. We have two units. We have the isolation Kondele site, which we had opened after the surge. Then we have the old isolation, which again we have retained for critical care support, which has a bed capacity of about 10 beds, even though we have only 5 high flow equipment. Now, what we are seeing here, the admission trend and mortalities. Yeah? The admission are the blue graphs that we can see here. We had the first wave here, then the second wave went down, and these are the totals for last year. Then this year, we are seeing a rising pattern, of course, of admissions, and this probably shows that we have not reached the peak of this epidemic within Kisumu County. Again, also you can see the pattern of mortality is also rising. So comparing last year and this year, you can see that this year we tend to have more cases of admissions. Now, in terms of profile of cases, the severe ones and the critical ones as well. Of course, these patients who present to us in the facility already in need of oxygen. Some of them, of course, come at critical levels. Some again also come in as referrals from other facilities. Now, cumulative data of age and gender. There's a pattern that we have observed this year, but again, cumulatively, we can see we had more males being admitted than females, even though within the age bracket of 20 to 40, we tend to see more females. Now, in the month, since the pandemic began up the month of March, we can see we had a pattern of more males, being admitted compared to females, apart from this age bracket here of 22 to 30. But now, from the month of April to the current, we can see between the age of 31 to 40, we have more females. And of course, in the other age bands, we have more males being admitted. Now, we broke this down to the various specific months just to study it further. And we observed that we are having more females being admitted. And you can see in the month of May, in this age group alone, 31 to 40, we have a marked increase of the number of females being admitted. In the month of June, again, the pattern still continues, but again, also among the elderly, we are seeing more females being admitted compared to males. And again, remember, these are patients who we are admitting who require oxygen. When some of the reasons to which we attribute to this pattern of changes, of course, we have quite a number of relaxed protocols within the village, and we are having more funerals, more people are being buried, people are still gathering for these funerals. Of course, as somebody mentioned, our culture probably could be facilitating some of these infections. Now, when you look at the sub-counties, the distribution of cases per sub-county, we compare the month of May and the current month of June. We can see in terms of numbers, the month of May, we had more cases within the Kisumu township area compared to the periphery. But again, in the month of June, we are seeing more cases coming from the periphery. A good example is the Nyakach sub-county, which is a bit far from Kisumu, I think about 30 to 50 kilometers from Kisumu, getting more cases in this month of June. And again, what we're getting from the ground is that we have quite a number of funerals being held in those areas. Proportion-wise, again, we are still seeing the same distribution of having more cases coming from the peripheral areas of the county. Now, in terms of mortalities, the same pattern that is expected, of course, more of the old tend to die from this disease. This is just the proportions of the same, and we are seeing the age. Those who are above 60 years tend to have more mortalities. Again, also comparing last year and this year, we are seeing a pattern of increased mortalities, again, also in the age group of individuals below 50 years of age. Similarly, also in the elderly, we're also seeing a spiking number of mortalities also, that is above 61 years of age compared to last year. Now, in terms of comorbidities, you can see the distribution here, mostly those who are hypertensive and diabetes leading, of course, followed by HIV and those with kidney disease. For those who have comorbidities, actually represent about 55% of the admitted cases. More males have been affected than females. Currently, in our isolation as of yesterday, we had 67 cases admitted. You can see here we have more females than males in our isolation unit. In terms of management, I'll just briefly take you through what we do. For the moderate cases, those who require supplemental oxygen, of course, we optimize medication, diet, feeding, and psychological support. These are the patients who will want to keep in the Kondele site where we have most of the beds, but in the old isolation, we have restricted it to patients who require higher oxygen flows of above 10 liters per minute, because these are patients who are likely to deteriorate. And of course, we'll want to put them on the NRM, means of oxygen delivery. Of course, we'll optimize steroids, we'll do BGS, CRP, just to see on how we can escalate the level of care. We also notify the anesthesia team and the physicians whom we work with closely, and of course, see if they are, supposed to be put on high flow, nasal cannula, or ventilation, or ventilation via CPAP and NIV. This is a mask, that we have seen to kind of work well for us, as opposed to the traditional non-rebreather mask. It has a tight sealing that helps in at least concentrating the oxygen a bit better. So this has actually worked for us for most patients, and especially with the limited capacity of the high flow oxygen delivery devices. This mask has really been quite useful. Now, in terms of medication, the usual cocktail is here. And of course, I think I want to go through this. It has been touched on by our colleague from Kenyatta University. The labs also the same. We do these spectrums of labs depending on the patient's condition. So at least can help us to make decisions on how to escalate the level of care in terms of medication, or we step up to the high flows or the ventilation. Now, for home-based care, just some of the emerging issues that we have observed, within our facility, and of course the county in general, are the home-based care patients. Now, of course, there's need for outpatient services for these patients, because we realized that, as opposed to last year where these patients were presenting to the facility, and of course, the initial diagnosis is being made when they are already desaturating. But currently, we are seeing patients who had been diagnosed earlier, they're at home for home-based care, but they are deteriorating. So options for earlier management with anticoagulation and steroids is something that we are having discussions with our physicians and to see if we can start this. But again, I know, as Umbajo had mentioned earlier in the presentation, we may not want to do this earlier, but again, we are still having discussions to see if we can tame this disease earlier, the inflammation and the like, so that at least, because we have a lot of pressure, of patients coming in requiring oxygen, and of course, there was an observed progression. So if we can tame it earlier, probably when they're getting to the moderate level of saturation of between 90 to 94 there, maybe we can start some level of management with these medications. So these are conversations that we are still having, and of course monitoring. Where these patients are on steroids, we may require escalation of monitoring, like having glucometers at level 2, 3, and where even possible, if there's a huge surge, even the CHVs may also come on board. The same way we manage to tackle HIV, TB, and malaria. Now, of course, we have the challenge of bed spaces, and of course, within the LREB region, the Lake Region Economic Bloc, of course, there's that need to know, the bed spaces available, because sometimes patients require bed space and then they're not able to get. So that collaboration within the region have been, quite useful. And of course, in terms of oxygen supply, human resource, and to know where we have some of these critical care support, equipments. Some of the emerging issues, of course, I've said earlier, late presentation at our facilities, referral system, and as had been mentioned by our colleague from Kenyatta University, feeding is a huge, huge problem for these patients, because most of them are elderly and the likes. Then, of course, medication. In terms of public health structure, well, we still don't have clarity. Of course, if you look at systems like the HIV, TB, malaria, they tend to have structures from the national, county level, sub-county, and even to level 1. So at the moment, I think we need a lot of guidance and support in this area so as to establish systems that can work and help tackle this disease better. Data, of course, we have a lot of challenges. Of course, we still don't have, harmonized reporting tools and even admissions and the likes. So a lot of improvisation, and you'll find an indicator is missing. You need to add one, and you may miss that out on that. So I think probably back to the national government, if we can come up, we can have tools that can be harmonized, because at some point we're realizing that we have a lot of mortalities within the facility, which goes unreported. Like within the ward, you find a patient died, later on, COVID test done, turn out to be positive. Now, post-COVID care, this has been mentioned widely, and of course, the complications that come with COVID, the lung diseases, and coagulation disorders here and there. So of course, we are trying to come up with an MOPC, and of course, anticoagulation clinic for some of these patients. Referral protocol, I think I won't belabor so much on this, but we have tried to work with the community strategy where we have the CHVs reporting to the sub-county disease surveillance coordinators, who will get in touch with the emergency call center. We have an emergency call center at the former Kisumu District Hospital, who normally coordinate these referrals. Within our facility, we have the nurse covering, and there's isolation in charges who will help establish the available bed spaces. for the various referrals. We also have the inter-county transfers, but at some point we were overwhelmed in terms of numbers, and we did not have bed spaces. So we were actually referring to Siaya and other counties around us. And of course, we were doing this through the county nurses and the various hospital physicians. Some of the challenges and the measures we have taken are capacity. Of course, we've been asked this question, how many bed spaces do you have for male and female? It's a question which may be a bit difficult to answer at the moment because we always try to create more and more spaces. For example, if we have more males than females, then we occupy the available space. If we have more females, then we occupy the available bed spaces. Okay, but at the moment, what we are doing, we are trying to encourage as many private facilities around us to establish isolation centers, which again, as we speak right now, about 55 cases that we have. I mean, 55% of the cases we have in Kisumu County are actually being taken care of within the private facilities that we have in this county. So this has been actually quite useful to the county. Oxygen supply, we have an oxygen plant which will be mounted this coming Sunday. So we expect to start using it from next week. Currently, we are having the liquid oxygen, and whose usage actually has increased to more than 4-folds. We're also planning to pipe more, oxygen points to our medical wards and any other space that is available, just in preparation for the surge. And of course, as I've mentioned, reorganization of the isolation ward from time to time, so as to accommodate as many patients who require oxygen as possible. Of course, the workload increases. In the last 1 month, had a lot of pressure on the available resources, including the human resource. And you can imagine our initial isolation unit, we were hosting up to about 15 to 20 cases. The same staff being expanded to serve about the 67 cases that I've just presented. So it was quite difficult, of course, having 2 units from 1 unit, coverage day and night. Most of our staff were getting out of burnouts, and the moment we were working with the county, so as at least to get as many staffs as possible. Of course, with more patients, the quality of care also may not be at the same level, for the same number of staff. So we are really trying to work on the number of staff to help improve that. We have also reached out to the county government. We are getting staff from other peripheral facilities. Our partners, ICAP and the Kenya Red Cross, have also promised to recruit for us staff who will help in joining the workforce.
Please finish, Doc.
Thank you. I'm finishing. I think I'll move to vaccination, which is the last presentation. So far, I picked this from the CTREP that was presented this week. So far, we have vaccinated about 39,000 individuals. 30,000 have received the first dose, the second dose, about 6,400 clients. And you can see this distribution here. Majority are healthcare workers, and this group called the others as well. We're also seeing at least a good response among the elderly. And that is the end of my presentation. Back to you, Dr. Thank you.
Thank you very much, Dr. Neto. We wish we were nearer to help you with a large number of patients, but just encourage the team. You all are doing an excellent job. The number of cases may go up before they go down, and you may see some of the severe cases. I just wanted to make a few comments on treatment, and I share this, especially drawing from some of the presentation that you have made. So a few things around what you put your patients on. There was a very long list on what you put your patients on, and some of these questions have also come up in the chat. So one, someone asked about the issue of zinc and vitamin C and all those many vitamins. So one, there isn't sufficient data to recommend for zinc, but supplementing above the recommended dietary allowance is not necessary except in a clinical trial. So again, the excessive prescription of zinc is unnecessary. When it comes to vitamin C, again, there's really no evidence that vitamin C makes any difference, including high dose vitamin C. Previously, we'd reviewed vitamin D as well, and the data showed that vitamin D really, again, made no difference. So as far as management goes, all these prescriptions are not very useful. The other comment you made, before that I presented something here, what to avoid. Antibiotics, including azithromycin, ivermectin, and steroids at home. And just to talk about this issue of early steroids that you mentioned earlier, remember from time of infection, there are sort of certain phases. One is the initial viremic phase. This even starts before you see the first symptoms, and the highest level of virus is during that early, very early phase. After that, you go into an inflammatory phase. That's when you see, all the infiltrates in the lung, the severe pneumonias, and the rest. So in this viral replication phase, this is a phase where monoclonal antibodies, some antivirals may have some use. So things like remdesivir, for example. Again, as I said earlier, the evidence is, well, neither here nor there. Once you get to the inflammatory phase, that's where you want to use steroids, okay? So saying you'll give early at home in patients without respiratory symptoms is going to end up with more side effects than any benefits to the patient. So even as you come up with your home-based care guidelines, just stick to some of the evidence around what can and will not work. So there was also a lot of questions around that earlier. And the question of why is it that despite us saying this many times, azithromycin, zinc, vitamin D, and vitamin C still being prescribed, please go out and educate other people and educate the populations as well to avoid self-prescription. So just one question to just a few of the panelists. I think one for Dr. Elizabeth. There's a question that you responded to on the chat box, but I think it only went to the panelists. And Dr. Muya was asking the question, are these surges that we see purely because of new variants? Is it that previous infection is conferring no immunity at all to new variants? And what would be the best strategy then for vaccination? Is it to use different vaccine types over time or to stick with the same vaccine type?
Thank you, Dr. Chin. I hope you can hear me. At this point, we just don't know. We have some ideas of efficacy of the vaccines with the different variants, and we've definitely seen, at least for the alpha, these decreases in efficacy of the vaccine. And so, yes, using different vaccines would be helpful, except for we don't know. We don't have enough data to really suggest which one to move to, depending on which variant you have. And so the recommendation would be difficult to do at this point. But there is some limited data on what they've been seeing with, at least with the alpha variant, as far as immunity. And it doesn't look like there's any vaccine that, besides, I think the Pfizer was the best performing against the alpha, but we don't have enough data against the delta. And I think the other question, could you repeat the other question? I'm sorry.
I guess the other question was around these surges that we're seeing. Are they simply because of multiple variants coming in and out? If we had the same variant, for example, would that change the course of our cases, for example? Or what is going on with these variants?
More than likely, the surges are more than likely due to these variants coming in, and because they're more transmissible, meaning they can infect more people faster and more efficiently, and the immunity from previous infections might evade those immune responses from people who have been previously infected with other lineages. It's possible that that's why we're seeing these surges.
Thank you very much. So I'll ask Dr. Maritim to comment on two issues. One, there was a question of the issue of vaccination after infection. And two was the issue of if someone has had side effects to the first dose, should they go ahead and get the second dose?
So thank you very much for the two questions. The first one is about when to vaccinate after a COVID infection, a COVID natural infection. So there are different guidelines for that. And I was trying to respond to a query raised by Edwin on the chat, but it's good I'm able to give this feedback verbally to all of you. So the vaccine deployment guidelines give a recommendation of 10 days to vaccinate someone who has recovered, 10 days from the time of test. And this is based mainly on the time of the isolation, so that that person, even when they go for the vaccine, the risk to the other people who are at that venue is significantly minimized. So that's one guidance. When you read the inserts and the vaccine manufacturers' guidelines, they recommend a period of 4 weeks. When you read the WHO interim position paper, it gives even a longer period of about 6 months. And the rationale for that is that in the 6 month period, the antibodies that may be developed following a natural infection may persist in the body for a period of 6 months. And in a situation where we have shortages of vaccine, people who have recovered from natural infection have some form of protection and therefore can last 6 months. So looking at the diversity of this recommendation, when people ask me this question, my default answer is the 4 weeks interval. And in this 4 weeks, the main rationale is that when you give someone an antigen and they already have existing immunity in form of antibodies, you can have a shorter period of heightened immune response in response to the sort of like a booster dose. And we saw this initially where we talked to our colleagues and they'd say like someone was vaccinated, they had COVID and they had very, not really severe, I don't want to use that term, but they had exaggerated responses, including like a higher fever, more local symptoms around that injection site and things like that. So 4 weeks seems to be a rational period to wait. But as we can see, the range is anywhere from 10 days to up to even 6 months. So I'm giving a very fluid answer. For most of us who've gotten our second dose, we know that actually the second dose, for myself, I didn't get any side effects. I was expecting more side effects like maybe headache, fever, which I had not gotten before, but I didn't get. And many of people I've spoken to said the second dose was better to deal with in terms of the side effects. Talking about the second question, and this is about if people have already gotten side effects, whether they can receive the second dose. And I answered that question on the chat, but I would just want to emphasize there are only 2 situations where your second dose would be contraindicated. And the first scenario is if you develop anaphylaxis. Anaphylaxis is an acute emergency, which is characterized by airway obstruction, difficulty in breathing, a lot of life-threatening local reactions that you require resuscitation immediately after that anaphylactic reaction. So giving a second dose will be coating disaster because chances are you still have another anaphylactic reaction. And this can be due to the other excipients related that are part of the vaccine packaging process. So that would contraindicate a second dose, particularly for the AstraZeneca vaccine that we're currently deploying. Another contraindication, and this is from newer literature, would be if somebody develops the vaccine-induced thrombosis with thrombocytopenia, the clinical syndrome that was described, and Kericho shared with us their case of a patient who has that as a tentative diagnosis. And in this condition, the pathogenesis or the hallmark of the pathogenesis is development of platelet factor 4 antibodies that therefore persist. And therefore, that's the rationale for ongoing anticoagulation in these patients. So if someone's developed VIT syndrome following the first dose, it's recommended that they should not receive the same vaccine that induced that reaction for their second dose. And that's why you've seen in other jurisdictions, people, because this condition has been described more with the viral vectored vaccines, mainly we've seen a few cases with J&J and a few cases with AstraZeneca, much more cases with AstraZeneca than J&J. So some jurisdiction like in the European Union, they're actually recommending a different second dose for people who are at higher risk for that syndrome. And they've defined in the epidemiology, people who are younger than 30 years, as well as people mainly of female gender who've received the AstraZeneca vaccine. And in those settings, it's because they also have this other mRNA vaccines. In our setting, because of the cold chain requirements, we may not be able to deploy the mRNA vaccines fairly soon. So for people who might have had an episode of VIT syndrome, then you cannot give them the second dose. So those are the two main situations where your second dose may be a contraindication. For other mild side effects, things like myalgia, headache, fever, that's actually what vaccine is supposed to do. And we manage those symptomatically, and therefore they do not contraindicate a second dose. And it's recommended, even if you had those symptoms after your first dose, please go for your second dose of vaccine. Thank you very much. And over to you.
Thank you very much, Dr. Mary Beth, for that comprehensive guidance. There are many other questions around vaccines, and maybe at the next meeting, we could take a bit of time to handle the issues around vaccines. So we'll ask Dr. Mary Beth maybe to take us a brief presentation around some of the vaccine questions that have come up. There are a lot of questions, so we are not able to answer all of them. If you go to the Q&A answered section, you may see some of the answers. There's one that has been asked a few times. So even as we close, I'll just ask Dr. Nyukuri to comment on long COVID. So at the Kenyatta National Hospital, we have a post-COVID clinic. So you may also comment on some of the experiences and what to do.
Thank you, Chair. Yes, at KNH, we have a clinic that we see patients who have been discharged, who we had admitted, and we are following them up. And you'll find most of these patients do have one complaint or another post-discharge, commonly being fatigue, difficulty in breathing. Some may have memory issues, and I've actually seen one who lost his hearing. So what to do when we get these patients who have these long and persisting symptoms? Number one, we know that especially those who had severe illness or who are admitted at the ICU are more likely to get these symptoms, and these symptoms are more likely to persist for a longer duration than those who had mild disease. And one thing that we have seen and we normally advise our patients is these symptoms normally do improve with time. They may not recover full function, but they improve with time. And more often than not, what is needed is basically conservative management, addressing the symptoms that they have. For example, those who come with breathing difficulties after exertion, these are the ones you'd advise to do breathing exercises and to gradually escalate their activities, not go back and start doing what they were doing before they got ill. Also for fatigue, again, gradual increase in the intensity of the activity that they are doing will help. So take-home message is these symptoms do improve with time. We've seen those patients who have been with us for 3 months, some for longer, probably 6 months. And we have seen improvement just from conservative management. So don't be in a rush to prescribe drugs that probably may not be helpful to the patients. 2, those who have other underlying conditions, because you will find those who have diabetes, those who have hypertension also should be managed and the treatment optimized so that the other conditions are not affecting, or contributing to the long COVID. Thank you. I'll stop there.
Thank you very much, Dr. Nyukuri. So maybe now I'll ask, as we finish, sorry, we're trying to address very many questions that have come up. We have with us Dr. Anne-Marie Macharia, who's a pediatric ID specialist at KNH. Dr. Anne-Marie, you could make a comment, just a minute as we close.
Thank you very much, Dr. Lois and all the please. Am I audible?
Anne-Marie, just increase your volume a little bit.
Yes. Okay. Can you hear?
We can't hear you well. The internet
Hello,
connection.
am I audible?
Yes, now we can hear you.
Okay. I just wanted to make some very brief remarks on pediatric COVID because I've had a few questions coming from my colleagues at JOOTRH, and we expect to have more pediatric cases where there's a lot of community transmission. So for children, majority of them will still have just very mild symptoms of upper respiratory tract infection, but a small percentage, about 1 to 2%, may have moderate to severe disease. So for those who just have mild symptoms, it is supportive care. So managing the fever, giving them fluids, and making sure that they have a balanced diet. There is no need for extra vitamins and things like vitamin D and C unless the child has a deficiency, an underlying problem, or use of prophylactic antibiotics, as Dr. Lois has said, because I'm seeing a lot of children coming in with azithromycin. The things that we need to look out for in children is one, the multi-system inflammatory syndrome, for which the criteria are a child or adolescent less than 21 years who presents with a fever that has lasted more than 24 hours, and then clinically has signs of involvement of more than one system.
We have lost you.
Or neurological symptoms. Oh, sorry, Doc. At which point did you?
Just the last two sentences.
Okay. So involvement of more than two systems, and children may commonly present with GI symptoms. So abdominal pain, diarrhea, or vomiting. And your baseline test should include a hemogram, and where available, inflammatory markers such as a CRP and LDH level. These are the only children who will possibly need severe respiratory symptom with an increasing need for oxygen supplementation. Also look out for children who are presenting with a Kawasaki-like syndrome. I have seen about 4 of those, and they tend to have a rash all over the body that looks like measles, accompanied by oral sores and a mucositis and a conjunctivitis that is usually non-purulent. And those are the children who will benefit from intravenous immunoglobulins and steroids. But by and large, children are doing well. And I think if there are any issues, then they can be addressed by the team in Kenyatta. Thank you.
Thank you very much, Dr. Anne-Marie. And even for the sites that are beginning to see more children, please feel free to reach out if you have any questions or require any further support. So allow us to bring this to a close. It's almost 12:20. Many thanks for your patience and for hanging out with us until this point. To the panelists, thank you so much. We have learned a lot from you. We hope that you'll be available again to keep presenting to us. We hope to have the next webinar 2 weeks from now. Dr. Thuranira is trying to convince me about next week, but you shall be informed in good time. So thank you. Have a good weekend. For those in Western Kenya, take care of yourselves and educate the community. Goodbye, everyone. Lakini sana kwa nini?